Right, so I'm here to talk about post-ROSC management in children because I assume you all know how to do cardiac arrest management and acute CPR. So we're not going to go through that, but talk a little bit briefly about what it is, how we look after these children, what does post-ROSC syndrome look like, and what are various different investigations we use to try and think about their prognosis. So if you look at the scale of problem, well, there are two different disease pathologies essentially, and we should probably keep them separate between out-of-hospital cardiac arrest and in-hospital cardiac arrest. So we can't talk about them together because the prognosis and the outcomes are definitely very different. So number is roughly the same when it comes to out-of-hospital cardiac arrests as well as in-hospital cardiac arrest in pediatrics. But the survival is very different. In out-of-hospital cardiac arrest, for obvious reasons, the survival is only 5 to 10%. And within that group, the favorable outcome is less than 50%. So really, really poor prognosis. Whilst in hospital cardiac arrest, survival is definitely better. So about 1/3 to close to half the children would survive. And amongst those who survive, the favorable outcomes nearly 2/3 of these patients. And although this slide, this diagram comes from adult study, but fairly telling when you look at all those patients who would remain unconscious after ROSC, more than 40%, unfortunately, will not survive. And the majority of the reason for their death is severe brain damage, followed by cardiac dysfunction and multi-organ dysfunction, and clearly different for those who are awake or have some consciousness intact afterwards. So how do we then define the phases of post-cardiac arrest syndrome? Well, they're immediately post-ROSC, the first 20 minutes, we're looking at trying to prevent another cardiac arrest. And then we define it as an early phase between 20 minutes to up to about 12 hours, where we are trying to reduce the secondary damage, mainly to the brain, and if there are other organs involved, looking after them as well. And then we maintain that treatment for the first 72 hours and only start thinking about prognostication after that. And then beyond the 72 hours mark, we're going into recovery and rehabilitation phase. And the actual syndrome basically consists of 4 different arms. So the first is, of course, the post-cardiac arrest myocardial dysfunction, which causes hypotension, causes poor perfusion of the organ, which can then set off multi-organ dysfunction. Immediately after cardiac arrest, of course, you've had a hypoxic ischemic insult at that point, but then there is a reperfusion injury because now we've got return of spontaneous circulation, and that reperfusion injury can further cause damage to both the myocardium as well as the brain. So post-cardiac arrest brain injury, and that's the organ we are most worried about because we might have recovery of other organs. We do know that the hypoxic ischemic damage to brain is almost irreversible. And then we're also looking at the persistent precipitating pathology. So if we think about a child who's in severe septic shock and ends up having cardiac arrest, the septic shock still existent even after ROSC. So we still have to think about treating that and the impact that would have both on the brain and the myocardial function, etc. So those 4 different arms is what we call as post-cardiac arrest syndrome, and we're trying to focus on each one of these as we go along. And what exactly happens when we are doing CPR plus minus defibrillation? Well, clearly there is myocardial stunning because of the direct impact, but clearly the bigger damage comes from the global hypoxic injury. As I said, brain is the main organ we're worried about, and that also leads to an impairment of the cerebral autoregulation, so the blood flow is not intact and the perfusion is impacted. And the combination of those 2 things can then lead to cerebral edema, which then further worsens the cerebral perfusion and has an impact on the eventual outcome. Myocardial stunning, of course, with the global hypoxic injury as well as use of adrenaline and all the other drugs can cause cardiogenic shock, which then can cause pulmonary edema and then contribute to global hypoxic injury. As with any noxious stimuli, a hypoxic insult would generate a significant systemic inflammatory response, and this is what we sometimes see when children would develop multi-organ failure. Clearly, contribution from the cardiogenic shock as well as the direct injury from the inflammation can cause ARDS. That would further compound the hypoxia. So all in all, this almost becomes a vicious circle. Some children would also aspirate, like we had in one of our recent children, and that would contribute to ARDS and poor oxygenation. And then occasionally we would have loss of intestinal barrier function. So these children can perforate their their intestines. It can also cause bacterial translocation, which can further contribute to sepsis from an ischemic gut. And then, of course, the ongoing damage to immune function, kidney dysfunction, as well as ischemic hepatitis are all contributing towards multi-organ failure, which then again compounds the hypoxic damage and the inflammatory response. Coming to the brain injury, which is what we see most often, especially those who would survive to develop ROSC, is, of course, we know what goes on. The primary injury happens at the time of the cardiac arrest because there's very limited blood going into the brain. That then leads to an increase in intracellular calcium and decrease in the ATP and glucose, leading to early cell death, which causes primary energy failure. And then we come into a ROSC phase where there's some normalization and homeostasis, but then that actually causes further reperfusion injury. So a second hit with further cell death, oxidative stress and inflammation, which causes the secondary energy failure in the first 6 to 12 hours. And finally, when we talk about the ongoing damage from this hypoxic ischemic brain injury, the repair and remodeling that happens with astrogliosis can lead to a tertiary energy failure, which actually can go on for days to months together. And maybe not that very clear, but there is some evidence to support that the outcome following, the neurological outcome following a cardiac arrest causes ongoing impairment to the neurological function, which you may or may not see in a traumatic brain injury, for example. So that's to do with the tertiary energy failure. That can happen. I really like this diagram. This comes from the circulation and basically talks about various different phases of injury and defines what the injury mechanisms are within that phase, what the clinical symptoms are, how can we monitor that, and what treatment interventions we can offer, and eventually how all these individually will have implications to the child's prognostication. Pre-event, of course, we know the younger the child is, the worse their outcome. If they have any pre-existing condition, if they already got some interventions in place, like the Fontan, the cause for arrest, what led to the arrest, if it happens out of hours, as we know out of hospital cardiac arrests have poorer outcomes because the quality of CPR and the immediacy with which we can do interventions is less. And similarly, that might have an impact when you're talking about nights and weekends, those with congenital heart disease and pulmonary arterial hypertension have implications in their prognosis. And then the actual cardiopulmonary arrest. So brain injury, as we talked about briefly, the brain hyperperfusion followed by hyperemia with the reperfusion and hyperoxia, which then causes free radical damage. Of course, the inflammation that comes with it, the impaired cerebrovascular autoregulation. So there is some evidence to support that those children who have hypotension immediately after ROSC have a much worse neurological outcome than those who have normal blood pressure. Now, whether maintaining a normal blood pressure or achieving an optimum MAP target would improve their neurological outcome is something we don't know. Whether the hypertension is purely a reflection of how bad the arrest was, how prolonged the hypoxic period was, and the myocardial stunning that would come with it is kind of like, again, the chicken and egg situation like we talk about in intensive care. And this brain injury leads to coma, worsens the cerebral edema, can cause seizures and myoclonus, and of course encephalopathy. The myocardial dysfunction, as we spoke about, it peaks around 8 hours and resolves by 48 to 72 hours. And we do see it. If we do an immediate post-ROSC echo, you will see that the ejection fractions have severely suppressed, and the children would sometimes require significant doses of inotropes to maintain their blood pressure. But then over a period of time, it tends to get better, and this is what we define as myocardial stunning. And then the systemic ischemia perfusion I briefly spoke about can cause coagulopathy, hypertension, can cause pyrexia, which is actually bad for your brain, and hyperglycemia, etc. And then, of course, the persistence of precipitating pathology. So we need to look at that. How do we monitor it? Well, we do the full intensive care monitoring. We are also then looking at the organ perfusion, so looking at the ventilatory parameters, the acid-base balance, looking at inflammatory parameters. And if they've had a major hypoxic hit, of course, we do see kidney dysfunction, and not patient might develop severe renal failure. And then the question arises whether we would, how far we would push ahead with their organ support, and come to that a little bit later. And then the treatment interventions, well, of course, that's the full intensive care. If at the point of event, we do CPR, we try to optimize, make sure we can get as best an outcome, and then administer oxygen, vasopressors, fluids, etc. Following on from there. And what we would do here in intensive care is any child who has ROSC and comes to us gets a neuroprotective management for first 48 to 72 hours. And although this does mention targeted temperature management 32 to 34, we have adopted a normothermic strategy, because there is no clear evidence to support that hypothermia makes their outcome better. So the latest RESUS guidelines suggest that you can opt for one or the other, and I'll come to that in a bit as well. And as a part of overall neuroprotection, we're kind of doing what we would do for a severe traumatic brain injury as well. So manage normothermia, because we know that high temperature is bad for brain. It increases the metabolic demands. We keep the oxygen and CO2 levels within normal limits. So there is some evidence to support that hyperoxia post-ROSC is bad for your brain, bad for the neurological outcome. Although there's a recent paper, it's a single center, and they say that they haven't seen any difference between those who were hyperoxic or normoxic. I suppose clearly this could also be a chicken and egg, because hyperoxia could purely be a reflection of mitochondrial failure, so the oxygen is not being utilized. But what we can do when we're treating these children is, it's like, as a matter of reflex, when we are resuscitating these children, we'll have 100% oxygen. And it's very easy to forget in the heat of the moment that they're still on 100% oxygen when the saturations are high. Sometimes they may not have a good trace, so you would feel that their oxygen, their saturations are low, but when you do an arterial gas, you'll see that they are hyperoxic. So something for us to be very vigilant and consider dropping the FiO2 we are delivering as vigorously as we can. And normocapnia, just like traumatic brain injury, we know that the brain vasculature is very, very sensitive to CO2. So high CO2s tend to dilate the cerebral vessels, which means it can increase edema, whilst the low CO2s would cause vasoconstriction, which may be a good temporizing measure in terms of reducing the brain pressures. But in long term, that vasoconstriction means we are causing further damage to a damaged brain by causing ischemia. So it's not advocated. So everything as much possible within normal limits, normal blood pressure, normal glucose levels. If the child shows any signs of seizures, we treat them early. And that debate's still out there. Lots of centers are now using continuous EEG monitoring for these children post-ROSC. And it has prognostic implication when we look at the amount of time child has had seizures. but the jury is again still open whether treating these seizures actually has an impact on their eventual outcome. And then, of course, when we're talking about rehabilitation, we talk about early mobilization, etc. So this is what we are doing actually on our in our day-to-day practice when we're dealing with these children, and how we think about prognosis and how we start considering whether or not this child's going to do good or not is, of course, the as we saw in this first column, the pre-existing or the baseline condition the child has. Of course, how long the CPR was. We do know that an ongoing CPR without any return of spontaneous circulation for more than 20 minutes, the prognosis is really, really poor unless there's a specific reason for that to continue. For example, if a child is hypothermic, and we do need to make sure that we have warmed them to at least 30 to 32 degrees before we say there's no return. Whether it was witnessed or not, how soon the CPR was started, whether the patient had calcium and bicarbonate. Now that's actually quite interesting when you look at it. There was a large study done in US called ICU Resus, where they're basically randomizing to one arm which was conventional care and the other arm where they had a fixed package, mainly looking at how good the CPR was, and essentially no difference in the outcomes in two arms. But then they've gone back and done lots of secondary analysis on that data. Clearly, those who required calcium and bicarbonate have a worse outcome. Now, again, one could question that worse outcome because they had prolonged CPR. Therefore, they required all the extra drugs because you'd have had time to check their gases and administer more drugs. Whether that's a reflection of that or the actual giving of calcium and bicarbonate somehow worsens the outcome is very difficult to know. The number of doses of epinephrine, if it was a shockable rhythm or non-shockable rhythm, etc. Each of these has an implication, what the presenting pH was, and we do know that any child who has the presenting pH of 6.8 or less, the chances of survival are really small. Those who develop fixed dilated pupils early on. But as soon as they have ROSC, we are committed to giving them neuroprotection, unless the multi-organ failure is such that we just can't keep their organs going. For example, mega inotropic requirement, very severe shock, very severe kidney failure, etc., is again a marker of severe hypoxia. And then we start talking to families about how far we push this particular patient. Right. Sorry, I'm talking rather fast, so please stop those who are online if there's any thing that you would like me to clarify. So we've gone briefly through that. What do we do? Well, we optimize ventilation and oxygenation. So again, being extremely conscious that we are trying to prevent hyperoxia and, of course, hypoxia, given the fact that these children could have pulmonary edema, could develop ARDS, could have aspiration, pneumonitis, etc. And then keeping their CO2s within normal target range. And then treating their shock, ensuring that they have as normal a blood pressure as we can, preferably blood pressure that is towards the high limit of normal, just because we are now trying to protect their brain if we can, if their myocardial function is not that bad. So what kind of inotrope would you like to use for a post-ROSC child?
Adrenaline.
Okay, AJ says adrenaline. Ahmed points to the chart, which actually has all the drugs known to us except vasopressin. And so I think we used to use adrenaline because, as a matter of fact, the very nature of post-arrest shock is a vasoconstrictive shock. And we were less keen on using norepinephrine. But I think we're becoming a little bit more comfortable using norepinephrine over epinephrine, just because we have to bear in mind this is a very sensitive myocardium. So using adrenaline can increase the arrhythmogenic potential, can increase the oxygen demand of the myocardium. So one has to be extremely careful of using adrenaline. And if you're really requiring high doses of adrenaline, and that's how I work it in my head, is anytime we're using adrenaline more than 0.1, we're better off using noradrenaline in that situation, because you're again causing more vasoconstriction because you're using more of the alpha response of adrenaline rather than beta, because that's within the first 0.05 to 0.1 range. And beyond that, you probably having to deal with much higher side effects of adrenaline in comparison to NORAD. And what would they be? What would worry me in terms of post-arrest situation? Significant tachycardia, the arrhythmogenic potential, as well as lactic acidosis, which are far more commonly associated with adrenaline than with noradrenaline. So, I mean, again, using a balanced approach, seeing what the child needs and how, I mean, of course, by this point in time, they are in intensive care, and we would have the luxury to get an echocardiogram to know how good or bad their myocardial function is, whether we use a combination of noradrenaline with a dilator or use a small dose adrenaline plus minus something else to support the blood pressure is what we would use. We probably never use the butylin here, and on odd occasions we might use milrinone just to release the afterload a little bit. And then of course early seizure control, treating hypoglycemia. The thresholds for treating hyperglycemia have clearly become a bit more liberal than when I was training. And then of course trying to ensure that all the electrolytes are as well within normal limits. As a standard of care, we'd always put all these children on a cooling blanket, but not to cool them, actually to target temperature, manage them to normothermia is what we would do. Yeah. Sorry, just a second. Sorry. Right, and then this is what we're doing basically. These are the 6 strategies we're using to protect the brain mainly. Blood pressure targeted management, oxygenation, and of course carbon dioxide, as I said. Alongside temperature, we reduce the physical stresses by using full sedation paralysis, and then of course managing normal chemistry. So these are the 6 main arms of neuroprotection, whether in a post-trauma child or a post-cardiac arrest patient. These are this is probably the largest study in pediatric world on therapeutic hypothermia, and there were 2 papers that came out, one after the other in 2015-17. In one arm, they looked at what was called the THAPCA trial, and they looked at therapeutic hypothermia after out-of-hospital cardiac arrest and after in-hospital cardiac arrest. And as you can see, no difference was noted. And of course, hypothermia as a concept is still very interesting, because in animal models, it has shown an improvement in the eventual outcome. Unfortunately, we haven't seen any benefit of using hypothermia. What we also realized was if we avoided fever, we were doing a much better good for the patient rather than causing hypothermia. So when we started taking control of high temperature, the outcomes with hypothermia were very similar to normothermia. And that's why normothermia is more or less the standard of care that we use. And this is a little more recent meta-analysis, again from NEJM, where they looked at hypothermia versus normothermia after out-of-hospital cardiac arrest. And the results probably can be extrapolated for pediatrics. As you will see, there is no benefit in terms of the survival or the neuropsychological outcome. And then when we look at the side effects, well, hypothermia group have more arrhythmia and hemodynamic compromise than the normothermia group. So that's why we've adopted the normothermic approach. Although the circulation guidelines do suggest that in hospital cardiac arrest, you could also consider using hypothermia. And this is the paper I briefly mentioned from the US group, where they're looking at early post-resus hypertension, which is associated with increased mortality. The same group have used near-infrared spectroscopy to try and define what is called a MAP-OPT. So mean arterial pressure optimum, so trying to manage the NIRS and using cerebral autoregulation parameters derived from NIRS to define the mean arterial pressure targets. And so far, we do not know whether managing a patient on those MAP-OPT targets rather than the age standardized targets that we would otherwise use has any specific outcome benefit in terms of their neuromotor outcomes. Clearly, when we look at the in-hospital mortality in relation to the normoxia and hyperoxia, as you can see, hyperoxia is much worse outcome. And even when we're looking at the PaO2 levels, clearly the relative risk of poor outcome is worse when patients have higher PaO2. So this is something we can easily control, and we should just keep a close vigilance on that. Right. So that's kind of what we're talking about in terms of management. The other organ support is as it would go with any child who's presented with multi-organ failure. Probably important to also highlight, I talked about CO2 management, but if your child's lungs are completely flooded and he or she's got an acute lung injury, then we may not be able to reach the targets we have set, and then we have to use a common sense approach to not thrash the lungs. Although if the lungs are normal, we always say brain protection before lung protection, but we then have to find common ground so that we are not thrashing the lungs purely because we wanted to protect the brain, because eventually we'll make the outcome worse. Just talking a little bit about how we start thinking from very early on in terms of the actual outcome, how we would prognosticate this patient and think about. Motaz is saying, what is your opinion on current practice of pooling neonates? I'm under the impression it's done to reduce brain damage. Well, that's very interesting, Motaz. I mean, I must confess, I haven't read the literature around neonatal HIE. And I know there was a recent paper which caused more controversy in terms of the no difference seen with using hypothermia versus normothermia in neonates. It's clearly not my specialty, and I'm not 100% sure. The interest in hypothermia as a brain protector strategy is still not dead. So people are still studying it. There's an ongoing study called POLAR, where they're trying to stratify patients post-arrest to see whether the hypothermia would make a difference in one arm or the other. Clear questions which people keep asking is whether we're doing it early enough, whether we're taking too long, whether we're giving it too short, etc. So lots of people are still thinking about it as a potential strategy to help. But so far, at least in non-neonatal population, there is no outcome benefit that has been observed. So clinical examination is definitely the best. And if the child is awake, then of course you can assess their neurology clinically, and then you could decide whether or not they look like they will be doing well or not. Now, the clinical exam is slightly difficult, especially because if the child was unconscious post-ROSC, we've already given them neuroprotection, and as a part of that, we use quite heavy sedation, plus minus paralysis. And because in the pediatric world, the sedation is not something which we can easily reverse, unlike adults. So we can't do sedation hold and do a neurological examination based upon that. So we are sort of more heavily reliant on looking at the pupillary reaction, especially in the first 48 to 72 hours till we've taken the sedation away. And we do know that bilateral fixed dilated pupils from early on have a poor prognostic marker, although we do not use just that to define the prognosis for the patient. We're becoming more used to using the automated pipilometer. So that again takes away the subjectivity of an individual bedside person who's checking the pupillary response. And also there is some evidence coming out in terms of the NPI, which is the pupillary index, and that takes into account the time it takes for the light to reach the pupil and for the constriction to start, etc., and the actual constriction as well. The algorithm is not widely available because, of course, they have copyrighted it to the company. But there is some indication that that NPI could be a good predictor in terms of what the prognosis would be, and also to a certain extent of the intracranial pressure. Given the global nature of hypoxic ischemic damage, generally we would not use intracranial pressure monitoring for these children because we know, given the damage, we will see cerebral edema, but unlike what we use for traumatic brain injury, we cannot reduce that cerebral edema by aggressive use of treatments as well as doing decompressive craniectomies if it is not treatable. So that's why we do not use it. There's an increasing support for using continuous EEG, and EEG not just to monitor for seizures, but to also look at the background activity. So a very suppressed activity, a very, what's the word, I'm missing it, an EEG which is non-reactive, and then there are some quantitative patterns people are using, as well as looking at periodic discharges would all define whether or not this patient is likely to do bad. SSEPs are less frequently used in the pediatric population, but N20 is something, if it is absent, has got a very good sensitivity and specificity. And in terms of the imaging, well, almost 9 out of 10 or maybe more would have an early CT scan, which is done not to prognosticate, but just to ensure that there is no intracranial event, which has caused the arrest. Can have some prognostic value, especially if it shows a loss of gray-white differentiation and shows an early edema. But the main prognostic imaging we do is MRI, which is best between 3 to 5 days after arrest. Biomarkers are still more in an academic world and less frequently used in the clinical domain. So why is it important to neuroprognosticate, and what are the controversies? Well, clearly we're trying to define how a child would do, so trying to predict something which is an unknown at this point, at the point of ictus, hoping that the care and the interventions we are doing would help improve the outcomes from bad towards good. But they can also be used then to understand how aggressive we are in terms of treating this patient. So as I mentioned earlier, renal support is something we always think long and hard, especially if the renal failure is entirely related to the duration of arrest. So for example, if you have a child who's post-op cardiac or who's got a bad septic shock, and you know that the kidney function is poor because of that, might have a lower threshold to go for kidney support. But if it is purely related to with an extended period of cardiac arrest, we do wonder whether supporting their kidneys is actually going to make a difference to their eventual outcome. And in that situation, looking at some of the early prognostic markers, we do start talking to families, think about how far we are pushing it, whether or not we should have a DNA CPR at this stage, because if they've had an extended period of arrest, with our neuroprotective measures and organ protective measures, we know that if they had a second cardiac arrest, the second insult would make this injury almost unsurvivable, and whether it would be better and kinder to let that child go if they had a repeat arrest. And those are the discussions which can be fairly complex, and we have to deal with it with compassion and looking at what the family values and where they stand in terms of the understanding of the child's baseline condition. This is a score which they have been trialing, and it's called an RCAST score. And basically, they have categorized the initial rhythm, shockable, non-shockable, witness. So all the things that we know have contribution towards prognosis. Whether this was a witnessed arrest or what time ROSC appeared, the initial pH, lactate, and the motor GCS component have been given a score, and there is some early evidence to support that this has good value in terms of prognostication. And they've just recently done a multi-center validation study using this RCOST score for pediatric patients, something which we've been using traditionally, like, without putting it into an objective measure. We know that a lower pH is worse outcome, a higher lactate is worse outcome. Probably I should say not just the higher lactate, but how fast it clears probably has a bigger implication in terms of prognosis. And of course, the motor GCS and initial rhythm. And this is just a table to show how in each group they have classified the prognosis in terms of the RCOST, survival, good survival and poor survival. Right. So far, so good. Should I just carry on? So basically, just what are the different categories of circumstances before we talk about end of life? Well, one is, of course, we do not have a DNA CPR in place. We're talking about full resuscitation, re-arrest, and an intractable shock. And then we are not actively taking away any treatment, right? So we continue doing everything that we can. The second situation could be we limit. So we say we're not going to do any further CPR, or we are not going to give this child renal support if their kidneys were to fail, etc. And this could be either a and then this could be either because there have been previous discussions and there's some kind of advanced care plans, or we've had that discussion with the family and we've done that. Or it could be an active withdrawal of life support measures, which probably is the commonest cause of death in post-arrest situations, and mainly related to poor neurological prognosis, but on very rare occasions related to non-neurological prognosis. And then brain death, clearly, which is now called death by neurological criteria. And this would be a legal definition of a child being dead. So it's different, just to be mindful of all the different circumstances that we would have. Right. So I'll go away from here and then maybe very briefly talk about this. I know I'm very aware that we're coming to 3 o'clock. So if we think about why we are trying to neuroprognosticate and what we're looking at, well, we're looking at whether there is any recovery of functionality, what kind of time frame we're looking for that recovery, what the patient and family values are, and what their expectations are in terms of the child's quality of life. And then, of course, my confidence with each of these predictions, how confident I can be in saying, oh, this is clearly going to be bad, or this is going to be good. And then assessing the current function, the neurological function, serially without sedation before we finally reach a consensus point. So at times it's not an active withdrawal, but once we reach a point where we think the child has some breathing function, but we know that they may not sustain life off the ventilator. We talk about a one-way extubation. And then we talk to the family and come to a conclusion that putting this child to further ventilation is not going to help, because all we are doing in this neuroprotective phase is giving brain as best a chance to recover. And beyond that point, any additional ventilation is not going to add to neurological recovery. So what are the prognostic choices in PQ? Well, devastating brain injury patients, crucial timing, done by physicians and family together. in terms of predicting where we are steering the care. And we're talking about poor outcome in terms of death, disability, and technology dependence, and certainly very frequent occurrence right now in our PICU, and doing it in with a combination of clinical exam and investigation. There's just some pediatric core outcomes set for cardiac arrest in children as produced by ILCO. I will not go through each one of these individually. Is probably worth looking at and thinking about how we make these decisions, which are quite complex. But clearly, the best indicator is the neurological exam, and this was a survey done across Europe, both pediatric neurologists and pediatric intensivists, and as you can see, an agreement overall that neurological examination and MRI brain are the best prognostic markers, and an increasing experience and interest in using continuous EEG. And then talking about because I think the key here is to understand that once we've decided that the prognosis is futile, it almost becomes a self-fulfilling prophecy, because based upon that, we would take the ventilator away, which actually means the child would die. So it's then very difficult to ascertain whether the child was going to die or whether the child died because the prognosis was considered poor and then the life support was withdrawn. Just very interesting data from mainly adults, but applicable to pediatrics as well. And when we talk about the actual statistical confidence in using GCS, so for example, motor score less than or equal to 3 at 72 hours has got a sensitivity of 74%, but a false negative rate of 27%. So we do have to bear that in mind. Specifically in pediatric population, because as I said earlier, our standard sedation analgesia is morphine mid-as, which can take longer to wear off, and as well as an occasional patient who might end up on thiopentone infusion, so a prolonged period of that. So we do have to take that in account and give child a benefit of doubt. Absent corneal reflex has actually a very high specificity, 95%, but a poor sensitivity. Pupillary reaction absent has, again, a very high specificity and poor sensitivity. But interestingly, a false positive rate of 0%. Myoclonus is bad, especially if it is a sustained myoclonus. It's seen in 1/5 of the post-cardiac arrest patients. And when they do see it, it's the outcomes probably bad. EEG is again becoming a hallmark and a cornerstone for prognostication, mainly the reactivity. So a flat EEG or an unreactive EEG is bad. If it has lots of periodic epileptiform discharges or burst suppression, it's really bad. Again, a very high specificity for poor outcome. And then, of course, alpha delta ratio in the quantitative EEG world is something which is gaining some prominence and an early indicator of outcome, especially when used in a continuous format. There are neurophysiological investigations, especially the somatosensory evoked potentials. Again, the N20 responses at 72 hours in adults. Well, if it is absent, then it has 100% specificity for poor outcome. And if it is present, then about 40% sensitivity for favorable outcome. We do not use it as frequently in the pediatric population. And of course, this has to do with the resource limitation and the expertise required for interpretation. So very quickly trying to finish it, when it comes to brain imaging, as I said, universally, most of these children would have had an early CT head, and if it shows cerebral edema with some sulcal effacement and gray-white attenuation, then we start thinking about poor prognosis. And there is an increasing interest in what is defined as the water ratio, and that is related to poor outcome as well. So again, good specificity, slightly lower sensitivity, and false positive rates of 0%. Of course, the best sensitivity is with the MRI done after 72 hours. So looking at the diffusion changes, and then again, a very, very high specificity for the patients. So if we think about the rough sequence of neuroprognostic tests following cardiac arrest, well, of course, serial neurological examination, as I said, early EEG being done continuously, early CT can be used. And then, of course, beyond 72 hours, we're looking at doing MRI and using further electrophysiological tests to help. This is really self-explanatory. So we avoid the confounder, especially when we're starting to wake up the child, to make sure they're not hypothermic, they're not still under the effect of sedative drugs. And then we start thinking about obtaining further information, especially if they're not withdrawing to pain. So we know that their neurology is quite suppressed. And then we're trying to look at all the other indicators plus the actual arrest. And then think about whether we are ready for any kind of prognostication, whether the patient's heading towards brain death, etc. I'll not read this, but these key messages from the 2020 evidence update in ICM are quite important and useful to know. So I'd suggest maybe read them, try and understand how people are using different investigative values for prognostication. And that is it. Thank you.